This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Hi, everyone. I hope you're having a great day. Today, I'd like to start off our discussion with an analogy. Let's say you turn on your television and you notice that the picture quality isn't quite right. After some inspection, you find that your cable wire is damaged. There's a spot where the insulation has been stripped away and the wires are exposed. Hopefully, this isn't from mice, because then you have a whole other issue to deal with. Because of this damage, though, not all of the signals traveling through the cable are making it to your television, causing a disruption in the picture. Makes sense, right? Well, with multiple sclerosis or MS, the protective coating on our nerve cells, called myelin, gets damaged, disrupting the signals that travel from our brain to various parts of our body. And this disruption produces a wide variety of problematic symptoms, which we're going to talk about in today's lecture. MS was first identified as a unique disorder in 1868 by the neurologist Jean-Martin Charcot. The name multiple sclerosis was chosen because multiple sites throughout the central nervous system are affected by this disease, and sclerosed, or hardened plaques of scar tissue, are one way it's manifested. MS happens to be the most common non-traumatic disabling disease that affects young adults. In most cases, MS is detected between the ages of 20 and 50. Less than 1% of cases occur in childhood, and only 2 to 10% of cases occur after the age of 50. This disease appears to affect women more than men by a ratio of 2.5 to 1, leading some to speculate that hormones play a role in the noted sex differences. Thankfully, patients with MS have a life expectancy similar to that of the general population. So MS primarily appears to affect quality of life rather than quantity of life. At a few points in this course, we've talked about neurons, which are specialized cells in the central nervous system that allow the exchange of complex information. The axons of these neurons, which carry signals or information that will be shared with other neurons, are covered in a myelin sheath. This sheath, like a cord, insulates the axons and allows messages to be sent smoothly and quickly. Well, in MS, patches of inflammation damage the myelin sheath, the nerve fibers themselves, and the specialized cells that make the myelin. This, in turn, disrupts the transmission of messages inside the brain, as well as messages coming and going from the brain to different parts of the body. MS is very individualistic. If 10 people with MS were in this room right now, they would most likely all present with different symptoms, different patterns of disease activity, and different patterns of progression. As is the case with every other disorder we've discussed so far, it's complicated. In general, though, individuals with MS will have a history of various episodes of neurologic symptoms, so they come and go, that are directly related to those patches of inflammation in the central nervous system, which can cause plaques to form. These plaques can sometimes heal, and the person's symptoms, for the most part, will subside, although conduction, so the transmitting of information, may be slower. For the most part, though, the patient will return to a fairly normal state of functioning until one day, out of the blue, another attack occurs. Over time, these attacks will cause some scarring to form, and the accumulation of scarring over time will ultimately lead to the progression of various MS signs and symptoms. Keep in mind, however, that although some patients follow this progressive course of symptoms, others may have a very mild form of the disease that produces little disability over time. The pattern that an individual person might exhibit can't be predicted by anything we can measure in the body, through life activities, or by the steps taken to manage the disease. We even see different patterns in individuals within the same family. So how does a person get diagnosed with MS? Well, as you may already know, there is no definitive test for this disorder. Rather, MS is diagnosed based on a patient's clinical history, symptoms, brain scans such as MRIs, evoked potentials, and even sometimes samples of cerebrospinal fluid. An MRI is used to find the plaques or scar tissue we've been talking about. These can appear anywhere in the central nervous system, although some of the more common sites include the gray/white matter boundary in the cerebrum, periventricular regions, so areas around the ventricles, cerebellar white matter, the optic nerves, and the cervical portion of the spinal cord and the brainstem. Although many think of MS as solely a white matter disease, research shows that MS lesions can also be seen in cortical gray matter, especially in more progressive forms of the disease. Evoked potentials are tests used to measure how quickly messages are traveling throughout the brain. They can be used to look at things such as visual, motor, somatosensory, and auditory messages. Abnormal nerve conduction could signal the presence of MS. Finally, a sample of cerebrospinal fluid, which is obtained through a spinal tap or a lumbar puncture, can be used to examine proteins for the presence of something called oligoclonal bands. These bands suggest the presence of inflammation in the central nervous system and are seen in 9 out of 10 patients who have a well-established pattern of MS, though less so in patients with early or mild cases of the disorder. A sample of cerebrospinal fluid is usually examined if a patient's MRI results are inconclusive, but a clinical picture is suggestive of MS. To be diagnosed with MS, patients must exhibit damage in at least 2 separate areas of the central nervous system, which includes the brain, spinal cord, and optic nerves. There must also be evidence that the noted damage occurred at 2 different points in time, and other possible diagnoses must be ruled out. So as you can see, a diagnosis of MS is reliant on finding central nervous system damage across both space and time. In terms of symptoms, 2 common ones are sensory disturbances like numbness, tingling, itching, and burning in various places throughout the body, and walking difficulties due to fatigue, weakness, either in one or both legs, loss of balance, tremor, and spasticity, which is the simultaneous contraction of many muscles. This can cause tone to increase in all muscles, the limbs to feel tight, and movements to be slower and less smooth. Patients may also experience vision problems due to optic neuritis, so demyelination of the optic nerve. These problems include diplopia or double vision, blurred vision, and pain during eye movements. Intestinal and urinary dysfunction, so constipation and bladder issues, are also commonly experienced. Other common symptoms include dizziness and vertigo, sexual problems, general fatigue unrelated to any specific activity, and pain such as aching muscles, shooting pains, and jabbing facial pain. Lastly, up to 65% of MS patients exhibit cognitive impairments that are unrelated to the duration of the disease or the seriousness of other MS symptoms. These impairments directly affect an individual's ability to work and maintain social relationships, impacting their quality of life. Cognitive impairments include those related to mood, so anxiety and depression are common, as well as those related to word finding, working memory, and even long-term memory, although information learned prior to the onset of MS tends not to be affected. Moreover, since MS patients process information more slowly, their ability to multitask or learn and memorize information is affected. Patients also experience visuospatial deficits that may affect their ability to recognize faces, drive a car, put things together, recognize differences between similar objects, and navigate unfamiliar surroundings. In addition, patients exhibit deficits in executive functions, including decision-making, organization, planning, and carrying out complex tasks. In spite of these cognitive difficulties, though, MS patients remain relatively intact when it comes to basic attention, basic verbal skills, and general intelligence. Less common symptoms of MS include swallowing problems or dysphagia, speech problems, so dysarthria, breathing problems, hearing loss, seizures, and headaches. 4 basic MS disease courses or types have been devised and updated by the International Advisory Committee on Clinical Trials. The most recent update was in 2013, though some clarifications were also put forth in 2020. The 4 types of MS are clinically isolated syndrome, or CIS, relapsing remitting multiple sclerosis, or RRMS, primary progressive multiple sclerosis, or PPMS, and secondary progressive multiple sclerosis, or SPMS. At one time, there was also another category called progressive relapsing multiple sclerosis, or PRMS, but that has since been folded into the other types based on advances in research findings. Let's briefly examine each of these types, starting with clinically isolated syndrome, or CIS, which is not technically considered a course of MS at all. I'll give you an example so you can see what I mean. A patient goes to see their physician because of recurring headaches. The physician orders an MRI to examine any potential causes of the headaches. The MRI shows central nervous system pathology that looks similar to the types of plaques seen in MS. These plaques cannot be explained by another diagnosis, and the patient of interest has no current or past neurological symptoms that have been documented on a neurological exam. So abnormalities are seen, but the patient does not meet the full criteria to receive a diagnosis of MS. They don't have plaques in multiple areas across time. So instead of MS, they get diagnosed with CIS. Research shows, though, that 50% of individuals diagnosed with CIS go on to develop MS within a 10-year period. Relapsing remitting multiple sclerosis, or RRMS, describes the initial course in 85% of MS patients and is seen more often in women than in men. In this type, mild symptoms come on acutely and gradually increase in intensity over days or weeks before resolving completely or nearly completely over weeks or months. Between these episodes, a person may have no neurological symptoms or only mild symptoms. To be diagnosed with RRMS, a person must experience at least 2 episodes and have evidence of 2 or more areas of demyelination. RRMS can be further characterized as being active, meaning there are relapses and or evidence of new MRI pathology over a specified period of time, or not active and as worsening, which is a confirmed increase in disability following a relapse, or not worsening. The third type, primary progressive multiple sclerosis, or PPMS, is only seen in 10 to 15% of patients. patients with this form of MS are usually older than 40 when signs and symptoms begin. This type also occurs about equally in men and women. It's characterized by the slow, gradual accumulation and progression of neurological symptoms in the absence of acute episodes. Spinal cord lesions are prominent, resulting in lower limb weakness and tightness, impaired walking ability, and urinary frequency and urgency. The last type, secondary progressive multiple sclerosis, or SPMS, can be seen in about 50% of MS patients who initially present with a relapsing remitting type after a period of 10 to 15 years. Here, each acute episode may leave the individual with permanent neurological damage and with permanent symptoms that accumulate over time. This type can also be further characterized as being either active or not active, as well as worsening or not worsening. So what are the causes of MS? Well, we don't really know, but scientists believe it involves the interplay of genetic and environmental factors or triggers. Let's start with the genes. We do know that more than one person in a family can exhibit MS. The concordance rate for identical twins is 25%. So if one twin gets MS, we know there's a 25% chance that the other twin will also get it. This percentage is much lower for fraternal twins and siblings, though, both of whom only share 50% of their genes. For these individuals, the concordance rate is only 2.5 to 5%. Many scientists would argue that although MS most likely occurs in individuals who carry a genetic susceptibility to it, this susceptibility must be triggered by infectious agents or environmental factors for the disorder to develop. Although the genetic basis of MS is complex, large international collaborative research studies have provided strong evidence for the involvement of at least 2 cytokine receptor genes, which are associated with immune function. These genes include the interleukin-7 receptor alpha chain gene, IL-7RA, on chromosome 5p13, and the interleukin-2 receptor alpha chain gene, IL-2RA. Thus far, over 200 genes have been identified as contributing to the risk of getting MS. Most scientists believe that abnormalities in the immune system most certainly contribute to the development of MS. In people with the disorder, the immune system fails to distinguish foreign invaders, like viruses and bacteria, from normal tissues in the body. As a result, the immune system actually attacks normal body tissues as well as foreign invaders. The result? Inflammation and tissue damage that is often permanent. This self-attack of the immune system against a person's own body tissue is called autoimmunity, suggesting that MS is an autoimmune disease. Research shows that in people with MS, specific white blood cells, called T lymphocytes or T cells, are present in the central nervous system. These T cells are primed to recognize and launch attacks against tissues of the nervous system, such as myelin. Researchers have found that there is a clear and specific reaction of T cells against proteins that comprise myelin in the central nervous system among MS patients. These T cells also help to activate B cells and other immune system cells that participate in the immune attack. People without MS also have these T cells, but not in the central nervous system like they are in people with MS. In people without MS, the blood-brain barrier in their necks blocks the T cells in the blood from entering the central nervous system. This means that in MS, for some reason, the blood-brain barrier is breached And these T cells are permitted to enter into the brain and spinal cord where they wreak havoc on myelin. Scientists are not sure why the blood-brain barrier is breached in MS, though therapies have been developed to help block this breach. One agent, a monoclonal antibody called natalizumab and marketed as Tizari, reduces the movement of T cells into the central nervous system. This, in turn, reduces the rate of MS relapses and helps to slow the progression of the disorder. Further evidence that MS is an autoimmune disease has been extrapolated from animal research with rats, mice, guinea pigs, and non-human primates. The animal model of MS is known as experimental autoimmune encephalomyelitis, or EAE. Similarities in clinical symptoms and central nervous system lesion patterns have been noted between EAE in lab animals and MS in humans. Turning to environmental triggers for the disease, among those identified are infectious agents like measles, herpes virus 6, so HHV-6, Epstein-Barr virus, especially in those with a clinical history of mononucleosis, chlamydia pneumoniae, a bacterium responsible for walking pneumonia, and hepatitis B. To confirm the link between these agents and MS, scientists track patients' antibodies. Antibodies are immune proteins that indicate a person has been exposed to a particular disease, like Epstein-Barr, for example. Scientists examine whether these antibodies are significantly higher in people who eventually develop MS than in control samples of people who don't get the disease. Other environmental factors associated with a risk of MS include smoking tobacco, which is associated with greater severity of the disease and more rapid disease progression, and geographic location. More cases of MS are found at the northernmost latitudes of North America and Europe, and the southernmost latitudes of Australia and New Zealand. Some speculate this has to do with decreased sun exposure, resulting in decreased vitamin D production, since vitamin D has a beneficial impact on immune function. Studies indicate that the time from exposure to infectious agents or environmental risk factors and the onset of disease is 10 to 20 years. So the preclinical phase of MS could in fact last decades. It has also been suggested that stress brought on by a broken relationship, losing a job, death of a loved one, and so on, may be associated with subsequent relapses in MS. Bottom line, it's the same story we've been telling for most of the disorders in this course. Genetics and environmental triggers combine in particular ways to determine the likelihood that someone will contract a particular disease. In this case, MS. As you probably have already guessed, there is no cure for MS, but we can introduce different types of therapies to aid with the underlying disease process and various symptoms. For instance, there are disease-modifying therapies that target some aspect of the inflammatory process of MS to prevent the inflammation that causes relapses. Some of these therapies include interferon beta-1a, so Avonex and Rebif, interferon beta-1b, so Betaseron and Extavia, glatiramer acetate, so Capoxone, and natalizumab, so Tisabri. Interferons are naturally occurring proteins that are produced when the body reacts to a foreign substance or to an agent like a virus. They belong to a class of molecules called cytokines, the hormone of the immune system. Interferon beta seems to calm the immune system. Glatiramer is not an interferon, but it works to inhibit the CNS immune reaction that produces damage and plaques in MS. And natalizumab reduces the rate of MS relapses and slows the progression of the disorder by reducing the movement of T cells into the central nervous system. We also have immunosuppressants that aim to decrease the severity and duration of MS relapses by suppressing the immune system. Mitoxantrone, so Noventrone, is an anti-cancer drug that acts as a strong immune system suppressant. High-dose steroids, like methylprednisolone, can also be used, but should be reserved for more severe attacks, as repetitive steroid use can have long-term effects like cataracts and osteoporosis. Besides disease-modifying agents and immunosuppressants, a wide variety of medications exist to treat different MS symptoms, like fatigue, spasticity, pain, and so on. In addition to medications, there are also practical guidelines that can help MS patients manage their disease. These guidelines include things like being as informed as possible about MS and asking questions, exercising regularly, practicing good sleep hygiene, living a normal, active life while adapting to any limitations, setting reminders for yourself, working to strengthen relationships with others, expressing a positive attitude, having regular medical assessments, and going to counseling or finding a support group. Things not to do? Do not withdraw from life and friends, for one. And do not expose yourself to a hot environment, as many feel weak, dizzy, or sick in a hot bath or on a hot, humid day. Avoid saunas and hot tubs as well. Do not try every drug, herb, therapy, and procedure without information on scientific evidence, possible benefits, and side effects. And don't feel ashamed or diminished because you have MS. Rather than follow the adage of rest with reasonable activity, those with MS should do the opposite. Stay active with reasonable rest. So slow down and rest more when symptoms and fatigue are a problem or when an attack occurs. But stay as active as you can and increase activity again when symptoms are relieved. Hopefully, you now have a much better sense of what MS is and how it's diagnosed, what the symptoms, types, and causes of MS are, and how we go about treating this disorder. Please join me in our next lecture where we'll examine different kinds of brain tumors. See you then.